Hi. We're tackling two really challenging pain management scenarios today, focusing on the unique needs of our audience, of course,
Hmm.
anesthetists and intensivists.
Right.
We'll be examining pain management in patients with sickle cell disease
Okay.
and also exploring the best ways to manage that acute pain that comes with a herpes zoster outbreak,
Yeah.
and really with the aim of preventing postherpetic neuralgia.
Both conditions, definitely unique considerations. We'll need to really understand those underlying mechanisms
Exactly.
and the latest evidence-based treatments.
Let's start with sickle cell disease. Now, we all know this genetic disorder is characterized by the abnormal hemoglobin,
Right.
and this leads to red blood cells distorting, taking on that sickle shape,
Yeah.
and that causes blockages in the small blood vessels, which, as we know, leads to those excruciatingly painful vaso-occlusive crises.
The burden of pain in sickle cell disease, I mean, you can't overstate it. I mean, these vaso-occlusive crises, they're not only the most common complication,
Right.
they actually increase in frequency as patients get older.
It's awful.
It really is. And then on top of that, a significant number of adults with sickle cell disease, we're talking 30 to 40%, they develop chronic pain syndromes.
Right.
So that just deeply impacts their quality of life and, of course, makes pain management an ongoing challenge.
And we know the mechanisms of pain here are complex.
Yes.
It's more than just that simple nociceptive pain.
Right.
From the tissue damage, the inflammation.
Absolutely. We're seeing more and more evidence of a significant neuropathic component as well,
Right.
likely due to alterations in the nervous system from repeated injury.
So how do we tailor management strategies knowing this, dual nature of pain?
Well, when a patient presents with an acute vaso-occlusive crisis, we need prompt and aggressive pain control.
Of course.
That's paramount. So we follow the WHO pain ladder,
Hmm.
which often leads us to, strong opioid analgesics like morphine. And we really want to get those medications in, ideally within the first 30 minutes
Wow.
of the crisis to really stop that pain cascade.
So in addition to the opioids, are there other things? Are there adjunctive therapies? I mean, what else can we do?
Yeah, for sure. Hydration,
Okay.
oxygen therapy,
Right.
really important.
To address those underlying physiologic factors.
Exactly. You've got to address the root cause as much as possible.
But we also have to acknowledge that, relying heavily on opioids,
Yes,
especially long term, it has limitations.
it really does. We've got to be mindful of the potential for dependence,
Of course.
tolerance.
Right.
And, there's a whole spectrum of adverse effects that come with opioid use.
Hmm.
So while they're essential, for acute crises, our ultimate goal should be to move towards preventative measures.
I see. To reduce the frequency, the severity of these painful episodes.
Absolutely. Reduce those episodes, reduce the need for opioids,
Right.
and ultimately reduce the associated risks.
Well, and thankfully, there are newer therapies emerging,
Yeah.
like hydroxyurea,
Hmm.
L-glutamine supplementation, crizanlizumab,
Yeah.
voxelutor, and these are really promising.
Very promising.
Crizanlizumab, for instance, it's a monoclonal antibody.
Right.
It specifically inhibits P-selectin,
Hmm.
which is that molecule involved in adhesion and vaso-occlusion.
Exactly. Stops that sickling process.
Right. And voxelutor, that works a bit differently.
It does.
It actually increases the affinity of hemoglobin for oxygen,
Right.
which again helps prevent that red blood cell sickling.
Exactly. Both aimed at preventing those crises.
So minimizing the need for opioids and therefore the risks.
Precisely.
Now, for those patients who have already developed chronic pain, what do we do then?
Well, then a multidisciplinary approach is critical.
Yeah.
Absolutely essential.
Okay,
We have to go beyond just the physical aspects of the pain.
I see.
You have to consider the psychological,
Mhm.
the social factors,
Right.
because all of that contributes to the overall pain experience.
So we need to be prepared to manage things like opioid dependence.
Absolutely. And that might involve a switch to buprenorphine in some cases,
Right.
particularly for those who are at higher risk. And then incorporating medications, that are traditionally used for neuropathic pain,
Wait.
gabapentinoids,
Okay.
tricyclic antidepressants. Those can be very beneficial.
So it's really about more than just pain management.
It is. It's comprehensive care
Yeah.
for these patients, their entire well-being.
Now let's move on to that second complex pain scenario we mentioned.
Okay.
Acute pain associated with herpes zoster,
Shingles.
shingles. And this comes from that reactivation of the varicella zoster virus.
Right. Same one that causes chickenpox?
Exactly.
Oh.
And it's important to recognize that reactivation, it's not just the rash.
Yeah.
There could be significant acute pain.
Absolutely. And unfortunately, some of those patients will go on to develop chronic pain.
Right.
Postherpetic neuralgia.
Which can be very debilitating.
Oh, it can be incredibly debilitating.
Yeah.
And really tough to treat effectively.
And the pain associated with herpes zoster, how would you describe it?
Often burning, stabbing,
Okay.
pulsating. It can be very, very severe. So recognizing it early,
Right.
intervening early,
Okay.
essential. Absolutely essential.
So what's key to effective management here?
Well, you need to differentiate between the nociceptive and neuropathic components of the pain,
Okay.
because the risk of postherpetic neuralgia, that increases with the severity of the acute pain.
I see.
So early and aggressive treatment is it's critical if you want to minimize those long-term complications.
So that's why it's so important to start that antiviral therapy right away.
Absolutely.
Ideally within the first 72 hours.
Yes.
Acyclovir,
Famciclovir.
famciclovir. These are the cornerstones of treatment, right?
They are. They reduce viral replication, but they actually have a really positive impact on pain control.
So it's not just about getting rid of the rash.
No, not at all. It's fundamental to the pain management strategy as well. And to further manage that inflammatory response, we often combine those antivirals with corticosteroids.
Okay. So much like sickle cell disease,
Yeah.
we're using the WHO pain ladder to guide management.
Yes. We might use non-opioid analgesics,
Okay.
opioids when necessary,
Right.
and then medications specifically targeted at that neuropathic pain component.
So what are we talking about there?
Gabapentinoids have been very successful.
Mm-hmm.
Tricyclic antidepressants,
Okay.
even topical capsaicin, that can be helpful in managing that nerve pain.
Now, are there any minimally invasive procedures that can provide pain relief?
Yeah, there are. Epidural steroid injections,
Mm.
either interlaminar or transforaminal.
Okay.
Those can really target that inflammation around the affected nerves.
And what about for those patients with refractory pain?
Well, then there's pulsed radiofrequency of the dorsal root ganglion.
Okay.
That's a technique that's showing promise.
And how does that work?
Well, it basically delivers a high-frequency electrical current to the dorsal root ganglion,
Okay.
which modulates those pain signals, but it doesn't actually cause permanent nerve damage.
Interesting. Are there other ultrasound-guided techniques?
Yeah, there are. Paravertebral and erector spinae blocks.
Okay.
They can offer more targeted pain relief with potentially fewer risks.
And why is that?
Well, the ultrasound guidance allows for really precise needle placement.
Mhm.
You can visualize the structures in real time, which just makes it safer.
So it seems that a multimodal approach is essential for managing both sickle cell disease and herpes zoster.
It is. And it's not just about the immediate pain relief. It's about the long-term impact these conditions can have on patients.
Absolutely. Untreated or poorly managed pain, in either case, it can have consequences beyond just physical discomfort.
Exactly. It affects emotional well-being, ability to function, quality of life.
So pain management, it's not just about reducing a score on a scale.
No.
It's about restoring function,
Yes.
improving their lives.
It's about helping them regain control.
And I think that's a really important message. It's about the whole patient.
It is. The whole picture.
Now, we've covered the mainstays of pain management for both conditions,
Right.
but this field is always evolving.
Always. There's always something new on the horizon.
What are you most excited about?
Well, there's been some really interesting research on ultrasound-guided erector spinae blocks for acute herpes zoster pain.
Oh.
Early findings suggest they offer excellent pain relief, potentially safer than traditional paravertebral blocks.
So it just highlights, how important it is to stay current,
It really does.
to keep learning,
Absolutely.
and to incorporate new knowledge.
Always learning, always evolving. That's what makes this field so fascinating. So building on that idea of a multimodal approach, let's dig a little deeper into the pharmacological considerations
Okay.
for managing pain in these complex cases. We touched on the WHO pain ladder,
Right.
but it's worth revisiting those core principles.
Particularly as they apply to to sickle cell and herpes zoster.
The WHO pain ladder, it really does provide that systematic framework
It does.
for choosing the right analgesics, based on the severity of the pain.
Absolutely.
So for mild pain, we typically start with non-opioid analgesics,
Right.
acetaminophen, and SAI.
Exactly. And then as that pain intensifies,
Right.
we progress to weak opioids,
Oh,
like
right.
codeine or tramadol.
Mm-hmm.
And for severe pain, particularly during an acute crisis,
Right.
we may need to go to the strong opioids.
Okay.
Morphine, fentanyl,
The
hydromorphone.
key is really individualizing that therapy,
It is.
taking into account their history with opioids, their response to treatment.
Absolutely. It's not a one-size-fits-all.
No, definitely not. And we can't forget about adjunctive therapies.
Oh, absolutely crucial.
These are the medications that aren't primarily for pain relief,
Right.
but they can really enhance those analgesic effects.
They can, or address specific aspects of that pain experience.
Right.
So for instance, during a sickle cell vaso-occlusive crisis, things like aggressive hydration,
Yes.
oxygen therapy,
Yes.
anti-inflammatories,
All incredibly effective.
because they target those underlying physiological factors
Yes.
driving that crisis.
You're getting to the root of the problem.
Right. And with herpes zoster, we often use corticosteroids.
Yes. Alongside the antiviral therapy.
Right. To manage that inflammation.
To really tackle that viral reactivation.
But even though opioids play a vital role, especially during a crisis, they're not without their limitations.
No, especially long-term.
Especially long-term. Tolerance, dependence,
Right?
those adverse effects.
It's a real concern.
So we always strive to shift towards those preventive measures
Whenever possible.
whenever possible. And if long-term opioid therapy is needed,
Right.
we have to be really careful
Extremely careful.
about monitoring them
Yes.
and implementing strategies to mitigate those risks
You have to.
of dependence and addiction. It's a tough balance, isn't it?
It really is. Managing the pain effectively,
Right.
but minimizing the potential harms.
Yeah.
That's where multimodal analgesia comes in.
Tell me more about that.
Well, by combining different types of analgesics,
Okay.
each with its own mechanism of action, and then throwing in non-pharmacologic approaches,
Right.
you can really target multiple pain pathways
At the same time.
simultaneously.
And potentially reduce the need for high doses
Exactly.
of any one medication.
And minimize the risk of side effects.
So, for example, a patient with sickle cell in a vaso-occlusive crisis, we might combine an opioid, like morphine,
Right.
with an SAAD.
To hit those inflammatory and neuropathic pathways.
And at the same time, IV fluids and oxygen therapy.
Absolutely, to address those physiologic issues.
And maybe even some non-pharmacologic things like heat therapy or relaxation exercises.
Yeah, you can incorporate those as well.
So with herpes zoster, acute pain, you might use a combination of antiviral, a gabapentinoid.
Like gabapentin or pregabalin.
Right.
Maybe a tricyclic antidepressant,
Okay.
hitting both the nociceptive and neuropathic components.
And a lidocaine patch.
Oh, yeah, for localized pain.
So it's really about tailoring that treatment plan
It is.
to the individual patient.
Recognizing that there's no one-size-fits-all approach.
Not at all. And early intervention is key
Oh, absolutely.
for both sickle cell and herpes zoster.
It can really make a difference.
Prompt and aggressive treatment.
Can significantly impact outcomes.
So for sickle cell, early pain management during a crisis.
Helps prevent that escalation of pain,
Right.
reduces the risk of complications,
Right.
shortens the duration.
And for herpes zoster.
Early antiviral therapy within 72 hours.
Ideally, yes.
Reduces the severity and duration of the rash.
And the risk of postherpetic neuralgia.
Exactly. It's crucial for patients to know those early warning signs
Right.
and to seek help immediately.
Because the consequences of delay.
Can be significant.
Yeah. So open communication.
Absolutely.
Strong patient-provider relationship.
Essential.
Now let's talk about the challenges of managing chronic pain
Okay.
with these conditions.
Because both sickle cell and herpes zoster
Right.
can lead to those chronic pain syndrome.
Which are notoriously difficult to treat.
They are.
So we need to shift our approach,
They do.
moving away from just acute pain relief.
It's more than that.
It's about the interplay of those physiological,
Psychological.
social factors.
Exactly.
So chronic pain, it's multifaceted,
It is.
often debilitating.
And it requires a more comprehensive approach.
A multidisciplinary approach,
You got it.
looking at the whole patient.
The whole person.
So for chronic pain related to sickle cell,
Mm-hmm.
we often have to consider a combination of
Right.
pharmacological interventions,
That's right.
long-acting opioids
Okay.
for baseline pain,
Mm-hmm.
neuropathic pain meds like gabapentinoids, tricyclics, and then non-pharmacological therapies.
Like physical therapy.
Right, to improve mobility.
Cognitive behavioral therapy.
Helping them develop coping mechanisms.
And even acupuncture.
Oh, interesting.
Which has shown some promise.
And with postherpetic neuralgia, how do we manage that?
Again, multimodal approach, gabapentinoids, tricyclics, topical analgesics.
Like lidocaine patches?
Exactly. And in some cases, we might even consider
Interventional procedures.
nerve blocks or even spinal cord stimulation.
For severe cases.
Yes, to modulate those pain signals.
There's no easy answer.
There isn't.
No magic bullet.
It's about tailoring that treatment plan to the individual.
Recognizing that what works for one
may not work for another.
Absolutely. It requires ongoing assessment,
communicate,
adjusting the plan as needed.
It's a journey, not a destination.
And it takes patience,
persist,
and a strong relationship
absolutely
between the patient and their providers.
A real partnership.
We can't forget those psychosocial aspects of pain.
No, we can't.
Chronic pain impacts emotional well-being.
Relationship.
Your whole life, really.
It can lead to depression, anxiety, isolation.
So addressing those psychosocial aspects?
It's just as important as the physical symptoms.
Right, so we might incorporate counseling, support groups.
Whatever resources they need.
It's about treating the whole person.
Exactly.
Not just their pain.
That's the key.
And that's where a multidisciplinary team approach can be so valuable.
It really can.
Working with specialists from different fields.
Pain medicine, neurology, psychology.
Physical therapy, social work.
We can provide that comprehensive and integrated approach.
Ensuring every aspect of their experience.
This is considered and addressed.
Now let's shift gears and talk about the critical care setting.
Okay.
Managing pain when patients are critically ill.
Right.
Unstable, unable to communicate.
It's a whole other set of challenges.
Unique obstacles.
Absolutely.
That demand a lot of vigilance and expertise.
For sure.
So in the ICU,
we often rely on objective measures, vital signs, behaviors, even biomarkers.
Because we can't rely on them telling us.
Exactly. They might be intubated, sedated.
Unable to communicate their pain.
It's a tough environment.
It is.
Demands keen observation.
And a deep understanding of pain physiology.
You have to be attuned to those subtle signs.
We have to.
And be proactive with pain management.
To prevent unnecessary suffering.
And improve outcomes.
We also have to watch out for
drug interaction,
adverse effects,
especially in critically ill patients
who are already on multiple medications.
Polypharmacy is a big concern in the ICU.
It is.
You need to really understand those medications
to ensure safety
and minimize those adverse events.
And we can't forget about sedation and analgesia.
Oh, so important.
Many of our patients are on ventilators.
Life-sustaining therapies.
That could be uncomfortable, even painful.
It's about finding that right balance between sedation and analgesia.
We need to provide relief.
But not over-sedate.
Right, because that can prolong ventilation.
Delay weaning, increase complications.
Delirium.
Prolonged ICU stays.
It really requires constant vigilance.
It does.
And attention to detail.
Titrating those meds carefully.
Monitoring their responses.
Adjusting the plan as needed.
That's what it takes to find that balance.
Exactly.
So effective communication is critical.
It is.
The whole team needs to be involved.
Nurses, respiratory therapists, pharmacists, physicians.
We all play a role.
We do.
Working together, sharing information, advocating.
To ensure they're getting the best care.
Which includes comprehensive pain management.
Pain management is a team effort.
It is, especially in the ICU.
It requires that shared understanding
of the challenges,
a commitment to communication,
and a willingness to adapt
to meet each patient's needs.
Let's shift gears a bit now and talk about the pain management considerations that are really specific to you guys.
Okay.
To anesthetists and intensivists in the critical care setting. You know, you're often dealing with some of the most acute and complex pain scenarios out there.
Absolutely, high stakes.
And so it's just essential to have all the tools.
You need a full toolkit.
And that deep understanding of the challenges.
For sure.
So for instance,
yeah.
Think about the perioperative period for a patient with sickle cell.
Okay.
We know that surgery, even a minor one, can trigger a vaso-occlusive crisis.
Absolutely. The stress, the changes in temperature,
physiological stress of it all,
oxygenation, hydration,
can all contribute to that sickling.
And that cascade of events.
Leading to a crisis.
That's delicate balance.
So as the anesthetist, you're not just managing pain during the procedure.
No.
You're trying to prevent a crisis.
You have to be proactive.
So what does that look like? I mean, what specific steps are you taking?
Well, meticulous attention to detail,
Okay, tell me more.
adequate hydration, appropriate IV fluids, maintaining normothermia,
Right, with warming devices
making sure they're oxygenated
throughout the whole process.
the entire perioperative period.
And pain control, of course,
Of course, that's essential.
which might involve regional techniques.
Like epidurals or nerve blocks.
Right, combined with that multimodal analgesia.
To minimize those opioids.
Yet it doesn't stop there, right?
It doesn't.
We have to think about managing that post-op pain.
Right. In a population
These patients
where opioid tolerance and dependence
are already concerned,
are huge concerns.
so they might need
higher doses.
we need to be watching for
Watching carefully.
respiratory depression, sedation,
And all those adverse effects.
so careful patient selection,
Absolutely.
close monitoring,
And early involvement of pain specialists.
if needed. We should also be thinking about
Non-opioid alternatives.
NSAIDs, gabapentinoids, regional techniques.
Anything to minimize opioid exposure.
Now, let's look at it from the intensivist's perspective.
Okay.
Herpes zoster pain
Right.
in a critically ill patient.
That's tough.
Imagine a patient on a ventilator
Okay.
who develops shingles.
They're already dealing with so much.
They're already so sick.
And now this incredibly painful rash.
On top of everything else.
And they can't even tell us how much it hurts.
Because of sedation, delirium, the ET tube.
It's a nightmare scenario.
It really is. So what do you do?
Well, you have to be incredibly vigilant.
Looking for any sign of pain.
Changes in vital signs,
Right.
tachycardia, hypertension, facial expressions, grimacing,
Restlessness, agitation,
anything that might be a clue.
and then choosing pain meds
Right, that's tricky.
with all the other medications they're on.
Polypharmacy, drug interactions, side effects.
It all comes into play.
It does. You have to consider their renal and hepatic function.
Their overall stability.
It's a lot to factor in.
So what might you do in that situation?
Well, you might start with IV acyclovir
For the infection.
and maybe a fentanyl infusion for pain.
But you'd have to titrate it carefully,
Absolutely, based on their pain and sedation.
monitoring their respiratory rate.
Closely, especially with opioids.
Because respiratory depression.
Could be devastating.
And what about adjunctive therapies?
Yeah, gabapentin or pregabalin.
For the neuropathic pain.
Help with that burning, shooting pain.
But again, watching for respiratory depression.
Always a concern.
It's a high wire act.
It really is.
Managing the pain but keeping them safe.
Especially in such a fragile state.
This is where our training really matters.
It does.
All those years of
That's where it
experience.
comes together in these moments.
So it's about a comprehensive approach.
Individualized to each patient.
Because there's no one size fits all.
There isn't.
We have to be adaptable.
Resourceful.
And always learning.
The field is always changing.
I think that's a great takeaway for our listeners.
I agree.